Welcome to this discussion on the value of vaccines and vaccination in the control of infectious disease. We are running this activity following an initiative that WHO launched in 2019, which was indeed the identification of the 10 priorities in public health. Among those priorities, priority number 8 was indeed vaccine hesitancy, at about the same level as the microbial resistance or the HIV epidemic. It is quite surprising that one of the major achievements in public health, which is the introduction of vaccines, enters now a category in which even professionals of medicine are challenging their value and they are hesitant in recommending vaccination to the population. So we have a panel of experts that will be discussing issues on vaccine use and vaccine efficacy and safety, and we have selected 3 main areas of interest. One of the areas of interest is human papillomavirus and cervical cancer, a cancer which is a disease with a stigma because of the nature of the transmission of HPV, which is mainly sexual behavior. We have selected flu because flu is a pandemic that every year strikes, and surprisingly low rates of vaccination among health professionals continue to occur. And Dr. Trilla will address the majority of the questions in relation to flu vaccination. We also have measles, a disease that for a number of years we thought it was eliminated from the European population, and only this year over 90,000 new cases have occurred in a number of different countries. A disease that could be eliminated and is not eliminated because of a failure in the confidence that the health professionals may indeed have in the value of vaccines. We will be answering questions and we will be discussing in the hope that this will help our colleagues worldwide to understand what we have, the potency of what we have in the prevention of disease and the ways to deal with vaccine hesitancy and anti-vaccine movements. So the first one of the questions is addressed to Dr. Trilla. Dr. Trilla is an expert in vaccines and vaccinology, and we will like to have an indication on what is the global value of vaccines, what have vaccines produced to human beings, and why we should continue to vaccinate.
Well, thank you very much. I think that you, in your introduction, make the clear statement. Vaccines is one of the measures, if not the one, with the better cost-effectiveness ratio and had improved the public health of all the population over the last century. We have increased the life expectancy because vaccinating children, we give them an opportunity to grow and become adults. Now we reduce the burden of disease, we reduce also the complications related to some infectious diseases that we can prevent with vaccines. And now, because we live longer, we are more focused on adding quality to the life and adding years of high quality of life at the end of our life. Now we are stressing the value of vaccination for all time, all life. And to become a better society, I think that we have to protect not only the children, but also the older people. Having said that, I was born in Spain in 1956. It was a polio epidemic, and we have no vaccine of polio at the time being. We introduced the vaccine a couple of years thereafter. Then on the next year it was the Asian flu pandemic, and I survived the polio and the Asian flu pandemic. And in 1968, it was again another flu pandemic, the Hong Kong flu pandemic, without vaccines. Our grandfathers remember quite well those diseases and the impact that those diseases have in children, in adults. And now, thanks to vaccines, we're living in a healthier society. But sometimes, as you mentioned, we forgot what could be this society without vaccines.
Thank you very much. Federico, we've heard in the last decade several instances in which polio was declared to be almost eliminated, and we tried to call measles an eliminated disease several times, but it seems that it never happened on time. Why is it the case?
Well, I think that we can follow on what Dr. Trilla has just said, and Probably the worst enemy of vaccines is their own success. We don't fear what we don't see. If we were seeing polio cases, people will be queuing to get the vaccine. Now, thanks to the vaccination, we are not seeing polio cases anymore. So you only fear the eventual problems that vaccination might pose instead of the real problems that the disease can cause in any person. A similar example we can have with measles. We are talking that before vaccination, 2,600,000 cases of death occur every year due to measles. Now we are below 100,000, and in well-developed countries we are not seeing measles, or we were not seeing measles until recently. So people don't fear what they don't see, and this can make us fall in self-complacency, make us change the target, and that's why, despite being near to achieve it, the concurrence of the new setting with the increase on vaccine hesitancy, the anti-vaccine lobby, and other different ingredients altogether may contribute that we are having problems in this last step. And I think that we are near, but we still can't fall in self-complacency, and there is a lot of effort to be done to ensure that we can get this achievable target, which is eliminate measles, eliminate polio.
Thank you. Alex, we know that the disease strikes very different developed and developing countries, and vaccines is a major business, is a major project that involves hundreds of thousands of professionals and population to get the vaccination campaign successful. What are the major international organizations that deal with the accessibility of vaccines in developing countries?
I think the World Health Organization is one of the major, and especially for Latin America, you have so-called PAHO, which is a large organization. Of course, you have UNICEF for under 5 years old, providing half of the vaccines in the developing world. And in 2000, Gavi was created. So this is a global alliance for vaccines and immunization at the time. So now it's the Global Vaccine Alliance. And it also was very important to assist countries at different levels, because providing a vaccine is one thing, but you need your health system to be strong and able to present the vaccine to your population. Another issue is, especially with new vaccines, they are priced very highly. And as a low-income country, you don't have any negotiation power to manufacturers to get affordable price for the country. And I think those international organizations really were key in order to get the different market price for developing countries, allowing low-income countries also to have access to the vaccine. I think also very important is sustainability, because introducing a vaccine is one thing, but keeping it and achieving high coverage over extended number of years is very difficult, as we see now in a number of crises. So, and there also they invest to make sure that countries are sustainable in getting high coverage once they introduce the vaccine. So they're really key in this story, especially for low and middle income countries.
Yeah. The new vaccines that are arriving, like the HPV vaccine, is initially extremely expensive as compared to the rest of the vaccines. Dr. Trilla, can you tell us a little bit how the price of a vaccine evolves as the vaccine gets introduced?
Nothing is cheap, and you have a lot of background of research, years and years, or sometimes unsuccessful research. Then you have to produce, and especially here in all the world, but with a high standard product, with a lot of quality and safety and regulatory issues. And pharmaceutical industry has the aim of making legally profit, and that it's also submitted to many kinds of regulations. So sometimes the price is quite high at the beginning. But thereafter, as has been mentioned, I think that the collaboration, the private-public partnership, some sort of collaborative funding could help to reduce the price of vaccines to those countries who cannot afford to pay the vaccine. The Gavi Alliance is a very good example, setting a lot of conditions in order to fund vaccines, and especially to make it sustainable all over time. And I think that the prices of the vaccines will be eventually being, let's say, reduced over time, but we have to keep in mind that we want a very good product, a very high quality product with difficulties in producing it and sending it to the market, and the whole world is not the same kind of market. We, as a high income countries, can afford sometimes to pay higher prices and also to invest from public health money to help those kind of organizations to lower the price to low income countries. Remember that besides vaccine hesitancy, that's a real and present danger here in all the world, there is also 1 million, 1.5 million children all over the world who still do not have access to vaccines that we have. So that could be also a very important issue, but I think we are in the way of trying to solving it in terms of price and tiering price and things like that.
Thank you very much. So let's turn now for a second on vaccine hesitancy. Vaccine hesitancy has been defined as an attitude or as a position in an individual or in a group of individuals that either denies any benefit from vaccines and refuses them all, or negotiates some vaccines against some other vaccines, accepting some of them and refusing others, or individuals who have some doubts about the value of vaccines but still are amenable to be convinced by an external source of information. These are usually individuals with wrong information or limited information, but they are ready to accept if the information is provided. But who are these individuals? What is the profile of a vaccine hesitancy individual or family or groups of individuals that are united one way or another? How would you describe, for example, hesitancy against measles vaccine?
Well, that's a complex question with no easy answer. When we talk about vaccine hesitancy, I think the first thing is to detect the hesitancy, to diagnose the hesitancy, and to make tailored decisions to the hesitancy. I mean, this is a common result, vaccine hesitancy, that as a consequence will have a decrease in vaccine coverage and will have a return in the disease, like the measles example. But the factors behind that hesitancy may vary from country to country, or even within the same country can be different regions or different areas with different reasons behind. So we cannot make one thing that covers all the possible spectrums of this problem. So I think it's key to have into account when we talk about vaccine hesitancy the different situations that can finally end in hesitation. And there is a continuum spectrum from the true anti-vaccine activists, which is a minority that had access to powerful social media and ways to spread their messages. But the really worrisome ones are those that are hesitant, that already have doubts, that can, let's say, block their decision to vaccinate, a decision that, for instance, is unconscious many times, that is more based on emotions and beliefs than on facts and science. And then we have to take into account how important is the behavioral part in this equation, and why to tackle with hesitancy is so important, a multidisciplinary approach with multi-targeted measures that take into account as a central part the social science and the behavior of the individuals. And in these regards, I think it's essential to consider that even those that accept to vaccinate their children or themselves may have doubts. And we are putting a lot of energy in the anti-vaccine group and even in those hesitants, while we have to reinforce the resilience of the people that is doing the things right. And these people can become hesitant or even anti-vaccine if we don't pay them enough attention. So measles is absolutely the result of a decrease in vaccine coverage. This decrease in vaccine coverage, the return of measles due to this vaccine coverage, is due to several reasons. Hesitancy, one of them, but hesitancy as a consequence of different scenarios in different places. So indeed, we have a very important problem there, where social behavior is essential, and only through information, education, and multi-targeted approaches, we should be able to really reverse the situation.
Do we have any institutions or any professionals that specifically deal with this problem? Or the health professionals are left on their own to improvise and to react to situations without any formal training or preparation?
Yeah, I think that what you mentioned is a very important point. It's true, now regulatory agencies like WHO and other big institutions start to consider this multi-targeted approach. They are starting to build these nudge units, no? Trying to really have this global approach. But at the end of the day, in the first line with the vaccinist or the potential vaccinist is the healthcare professional, I would say, the one that stands in front of the doubtful parent or the doubtful vaccinee, and is the key element in the process of both preventing the development of hesitancy or solving that issue. And probably we lack of enough, let's say, formal training of the healthcare professional in this new scenario, because vaccine hesitancy, as we are facing it, it was not like the classical anti-vaccine lobby or other situations we could have lived in the past. So I think, and I agree with your feeling, that we are not probably providing the adequate training and the necessary formal training of the healthcare professional to really tackle with the current scenario of vaccine hesitancy.
There's another example with the measles vaccine that was accused of being one of the causes of autism. And in looking at the web pages where this publicity is posted, you immediately see very rapidly that there is a promotion of alternative medicine, homeopathic medicine, alternative treatments for common diseases. There's a certain business behind that, because at the end of the day, you often find big judicial trials against either the government, the public health institutions, or even the pharmaceutical companies that produce vaccines. And that might be an element that keeps on moving that wheel, because the autism story started a number of years ago and is still alive and is still running around and is still damaging the confidence in vaccines. Is there a business of the anti-vaccine positioning?
I truly believe that. I mean, the anti-vaccine lobby is a well-organized lobby with specific funds, with specific campaigns, with specific media. There is registered more than 400 web pages and social media strictly spreading these messages, capting funds. So it's not something for fun or some pure individuals that make isolated decisions. So there is a true problem there that has to be tackled officially from many different perspectives, starting, for example, to control and limit how they spread the messages they spread without any basis, without any rationale, without any science, the way they do through the web pages or the social media. So that's one part of the issue indeed. Second, I agree that anti-vaccine comes with a lifestyle, let's say, or with other ingredients, because it's not that you don't vaccinate, but you don't vaccinate, and instead of this, I propose you this, and that. Homeopathy, natural science, and other business that are linked to this. So actually, there is a major business behind this. And also I would add that the anti-vaccine lobbies, as we see them, are related also to, let's say, middle and high income countries. I mean, because this is the kind of lifestyle that you can only afford if you don't see suffering, if you don't see disease, if you don't see the consequences of these entities. And in less developed countries, of course, vaccine hesitancy and anti-vaccines is not an issue. If you see your child die, or if you see your child suffer, if you see your child cannot eat, you are not concerned about exclusion diet or pure vegetarian things, or giving him homeopathy, or not vaccinating him. So I think that indeed it's a major problem behind this, an iceberg situation.
Any other comments?
No, I just want to add, my daughter had to make a work for school, and she picked vaccination, so I was very proud. And I sent her to the library in Belgium, in Antwerp, and she found 10 books, and 9 were anti-vaccine, and there was one relevant book on vaccination. So I think we really should be very careful, because sometimes we're not aware how much the anti-vaccine or vaccine hesitancy is spreading. And even at the city library, most of the books on vaccines are about anti-vaccine. So it might be worth looking in Spain or other countries. But there's so few good, valuable information, because we are so how do you call it has worked so good for such a long time, and so complacent. Oh, vaccines are there, they're good, why should we do something about it? We didn't do anything about it. And there's another group that is very active and is really promoting the other side. So we really should make more effort to promote the benefits of vaccination.
Yeah, one of the challenges of that discussion is that typically scientists, they would argue with information, with data, with peer-reviewed data, with publications. Whereas the anti-vaccine positioning, it's more emotion, it's more challenge, but do not provide data. It is not that there is data to be interpreted in a different way. They do not do studies, they do not run trials, they do not examine the fundamental of their arguing. That creates kind of a paranoid situation in which two different worlds, they speak, but they don't meet anywhere, they don't match. And majority of our colleague scientists have difficulties in confronting an anti-vaccine position in an open discussion or in a TV set. Have you had that experience yourself?
Yes, I have, personally. So, and I think that you pointed quite well what we feel. If we talk about clear anti-vaccine people, we'll talk in different languages. We cannot understand each other. They speak about faith, we speak about science. They have an idea, keep this idea forever, ignore all evidence against this idea, and keep it as much as possible. We try to convince them with data, publications. They show one paper, we show 500 million papers against this small paper. They believe this single paper, they ignore the other papers. So it's a different language. So my personal feeling is we don't have to spend many time trying to speak or convince true anti-vaccine people. Another very different thing is what those people that certainly had doubts, the vaccine hesitance. Then it's a dialogue. You have to speak with them, listen to their arguments, try to explain, make some kind of negotiation, wait, try to digest this information. Don't read this book, read this other book, don't go to this web page, look at this other web page. But certainly we have to learn some of the tactics that they use for giving social messages, because it's very boring to have any one of us explaining in a big TV studio a sort of data with graphs and things like that and saying, I have proof that this vaccine is safe, and then the next speaker is an active vaccine with a young kid that have strange disorders never related to the vaccine. They say, after being vaccinated, my son or my child has this strange disease, and people get very afraid about that. So we have to learn how to copy with that, but I think mostly the science have to prevail. We have to explain better some examples and don't fall also in some of the trumps that they use to catch us in the terms of dialoguing and things like that. And I think, I am quite sure that we will prevail, because as has been mentioned also, there is a very interesting issue on what Federico has said, that we have to applaud those fathers that decide to vaccine normally and their child, and then should be the social norm. So we have to say, you do it for your family, but you do it also for the rest of all, the herd immunity. That's an important thing, and people here in our society understands quite well there is an individual benefit, but also there is a social benefit. So we have to encourage all those people to say, this is for all of us, it's not for your kids only. And the other ones who did not vaccinate, they take advantage of all the families that vaccinate normally their kids. So I think that's a mixed balance of sentiments, but certainly against the true anti-vaccine people, my personal experience is my coronary artery gets a little bit thinner after discussing with them. So finally, some years ago, I decided not to argue directly with them. I just try to show that they are wrong, but not arguing directly with them.
Alex, in the majority of the studies that have looked at the shared responsibility on the promotion of vaccines, the majority of these studies conclude the central role of the family physician, of the healthcare provider at the front line, the one that interacts directly with the population, and the ones that need to be fully aware of, for example, a new vaccine, how it works, why is it used, how to use it, what are the possible side effects. how can you deal with the idea of communicating to the healthcare providers, first-line healthcare providers, and pass the information that they will need?
I think it should be part of the plan. If you have an introduction plan for a new vaccine, it's not only the budget to buy the vaccine, it's also the budget to do the communication, it's the budget to do the training, and even you should have a follow-up of your training. Check if your healthcare providers are still well informed and keep them informed annually or regularly. Because I want to come back to that, we have hesitancy, but we also have hesitancy with healthcare providers. And it has been shown, even if a person himself wants to be vaccinated and you go to a hesitant physician, you won't get vaccinated.
Yeah.
So this is really a key role. On the other side, if you're hesitant, but your healthcare provider is very convinced of the cause, you will get out with the vaccine, or you will come back and he will re-propose the vaccine until you say, okay, I agree. So they really have a key role in the whole process.
And do you think that when a new vaccine is introduced, we have also a budget to ensure health communication and information on the value of the new vaccines?
I think, and for HPV, UK is a very good example. They took 4 years to introduce HPV vaccination, making sure that everybody's trained, and they have a 6-month rotating survey to check which are the issues that are going around. They spread that among their healthcare providers so that they are informed, that they are able to answer the questions that are going around on social media. So they really need to be trained in advance, but also during the complete implementation.
Yeah, that's very relevant to organize a strategy to inform the health professionals. But then we have also the media in between. What do you recommend, or what do you perceive as the role of the media in communicating and creating a state of opinion in which the population will look favorably to the arrival of a new vaccine, for example?
Well, I think that's a key point, the responsibility of the media. And when I say responsibility, I'm not talking only about the part of the role they have, but they should take responsibility when dealing with vaccination. We often see with any new crisis on vaccination, with any issue, any doubt that can arise from vaccine in the normal life, let's say, how often media try to get this equidistant approach, like, okay, let's open a debate with the people pro and the people con, the arguments favoring the vaccination or unfavoring the vaccination. This, from a scientific perspective, and I think we all agree, is absolutely nonsense, because there is no evidence, no rationale to make this kind of debate. And this equidistance is a false, it's like a pose, I would say. And we should, let's say, honestly tackle with this and discuss that with the media that has an important presence and impact in people's opinion. Because from a scientific perspective, to state that I don't know if there is any causal or time relation with a vaccine and whatever effect, to say, well, let's reopen the debate, yes or no, it's like if you have, I don't know, a problem with terrorism and you reopen the debate if terrorism is good or bad. From a vaccinologist and from an evidence-based perspective, it's the same stupid thing. However, this is well seen and well received by the audience, and you're putting in difficult situation the argumentation regarding vaccination. So I agree that sometimes the media, with this self-pretended equidistance to the problem, reinforce the problem itself.
But I think then it's our role to inform the media and to train the media, because sometimes they're absolutely not aware. And we had, during our meeting in Colombia, there was also a journalist that said, at a certain moment we realized you cannot put somebody saying that there's no climate heating together with somebody who says that there is climate heating, because 97.7% of the scientists agree that there's climate heating, so it's a no issue. But you really need to train them. And then media, you have different levels in the country also. You have the national media, but then most cases they start at a local newspaper, local school, and then it bursts out. But I think we also need to train them and inform them.
And also, I think that some of us should be trained on how the media acts and how the media works.
No, it's vice versa. Yeah.
They have special deadlines, they want short statements, they want clear things, and sometimes it's not so clear. They want examples, they want images, and sometimes we are not prepared to do so. So I think to convey the right message, we have to talk with them, we have to learn from them, we have to explain how things are going, but at the end, the headlines are the headlines, and you never know what could happen on that. And probably it's more a headline, an adverse reaction, than 20,000 nothing at all to do. So,
but I think there's a good example from the UK again, where a girl killed by jab, by HPV jab. It was front page news, and there was no drop in coverage because they were on it immediately, and it was the next day already turned around, and then they even made it that the sister of the girl who died eventually got her HPV vaccine. So it's really a point of being there immediately when there's a crisis, and things will happen. We know that people die also after a vaccination, so there will be deaths after vaccination not related, and the high chance that is linked to the vaccine. It should definitely be investigated. So, but we should be prepared to respond to that. Yeah.
Yeah, this is a critical thing, and it is clear that the countries that have done best, they devoted quite a number of time and effort and investment to properly educate the population and the professionals. But other than that, let's turn for a second to the surveillance system. And anytime a new vaccine is introduced, or even vaccines that have been introduced for quite some time already, they benefit from surveillance for efficacy and surveillance for safety. Is it in new vaccines like the HPV vaccine, is it mandatory that each country creates its own surveillance system, or the vaccines are universal enough so that surveillance systems in some very well-equipped sentinel spots is sufficient to ensure that no side effect attributable to the vaccine will escape through the net?
No, I think you should have a universal surveillance system, because I think most of the issues that did occur with the vaccine were not really vaccine related, but were related to administration, were related to storage, and these are things that happen locally and that need to be detected locally. If you have a healthcare professional who doesn't store his vaccines properly, and there will be cases of contamination, and that has been occurred in the past by measles vaccine contaminated by E. coli and subsequent death just because there was no cold chain respected, there was no hygiene respected. So it remains things that could harm if you don't use them properly. So and therefore I think it's critical to have that adverse events following immunization system at every level, and then you will be able to respond rapidly also in case something happens.
Okay, but such crises occur once in a while, and we had examples in almost every vaccine. Are we ready for that, Dr. Trilla?
You are never ready for a good crisis, but you can be better prepared for facing it. So the old say that if you want peace, prepare to war. So the things should be done before in advance. You have to be very clear about what will be the procedure if a crisis arises, how sustainable is your position, what are the data, how to interpret them, and how to react as much as quick as possible. Remember that in a crisis, the one who is the first, who is credible, and who can give the best message, take the advantage, and then can lead the events. But people sometimes have a different perception of risk and what is the real hazard of one thing. So you have to be very careful listening to the problems that the people face, the feelings that they have before a crisis, and be enough patient to try to explain everything that's going on. In a very, let's say, normal crisis, it is very difficult to do because things that happen very quickly, you have to give clear statements. It's not easy to convey a clear message not minimizing the risk, but explaining the risk, and especially explaining the uncertainties that we have facing some situations. But I believe that we are better prepared because we have to face many crises, but crises will happen, and what we have to learn is from each one how to handle the next one and how to prevent, or at least be more prepared to handle those crises.
I agree with you when you say that we are never enough prepared for crisis, but I think you are very optimistic when you say that we are better prepared for the next crisis. When you look from certain distance the different crises regarding vaccination all over the world, they all have common ingredients. It's always the same, more or less, root, the same starting problem, how this is managed, where there was a lack of preparedness, things that we have already discussed here, like the introduction of the vaccine was not coupled with an adequate information and educational campaign, the information during the crisis was not ready, not taking the advantage. So it should be so easy that other countries learn from each other. So I'm doubtful that even the same country can learn from their own lessons well enough to be ready for the next crisis, although I agree that we should work on that direction.
But we have an expert board on HPV, and we did visit a number of countries where there was a crisis, and now we have published this in Vaccine, a small table, but I think it's very relevant what should be done prior to introduction, during introduction, when it's introduced, to keep it sustainable, what to do in a crisis, because as you say, there are very common denominators in all the different countries, but I think you should have a crisis plan in advance, not thinking, what did we do last time, how are we going to do it this time? That's too late. You should already know what to do and who does what, who will communicate immediately. Yeah. If somebody dies and there's a possible link, you should know who will call the newspaper and go and visit the family, and what he will or she will say to the family. So it's really a plan that needs to be there, and that can be adjusted for the next time.
Yeah, we all remember when the announcement of a pandemic flu arriving through birds or through pigs or in a number of different ways. The confusion that was generated in the majority of countries in Europe, where people were issuing different recommendations to vaccinate the elderly, vaccinate the pregnancy, vaccinate the children, use vaccines without adjuvants. Lots of vaccines were purchased up and down. That was a kind of a chaotic image that I think severely damaged the credibility of the medical profession, as well as on the flu vaccine.
Yeah, well, then the 2009 H1N1 flu crisis, I think, was a product of many factors, a new pandemic, an anticipated one. We don't have vaccine, we have to prepare vaccines. We don't have antiviral agents, we have to promote some antiviral agents, but mostly it was a problem of communication. It was a problem of communication because the WHO and some of the people inside the organization want to give, let's say, this kind of weather forecast for the whole world. And the situation in many different countries is quite different. Some of them had already the flu, some of them know months after that the flu is not so bad. It was a widespread flu, but it's probably not so severe, and they don't adjust the messages. So we have messages that we all die from the flu at the beginning, up to the end. This is nothing to be worried about, but you still have to keep the vaccination, you have to use antiviral agents. So for me, it was a problem of adjusting the messages according to the evolving situation and being able to say at each moment what should be done and what we know and what we don't know at the time that the crisis starts. But unfortunately, it doesn't go this way. So certainly many people say, what are you talking about? We don't have this problem here. Why you are saying that? Because we have news from Argentina or from Chile that things are not so bad at the time being. Why you tell us that we'll have to be vaccinated if you don't have the vaccine? And then when the vaccine arrives, we are in the middle of the outbreak. So it was a severe damage to the confidence in public health. And fortunately, thereafter, I think we learned something. I don't know if going to repeat some of the mistakes, but it was a very complicated time of being in a world crisis, with many people speaking about things, with health authorities saying different things in the morning and in the afternoon. So it's very complex to handle. So.
Yeah, I guess scientists are used to live in uncertainty.
Yeah.
Whereas the press and the politicians, they need certainty all the time.
They want clear statements.
Clear statements.
Yeah.
So, Alex, you've been through the Japanese crisis and the Colombian crisis for the HPV vaccine. What in these times of fake news, can you comment on this concept that a creation, a story that was created out of very little evidence can damage so badly two excellent vaccination programs that were in place in these two countries? We were discussing the need to have a communication plan ahead of time, an educational program for physicians, an educational program for the press. Are these things all failing in situations like the Japanese and the Colombian crisis?
I think things happen at different levels. So you have an event that's linked to vaccination. It occurred in girls. It was covered in the media extensively, in social media. I think also in both countries you had anti-vaccine activists, Japan and Colombia, and there were lawyers also linked to this. And I think also the position of the government was slow in Colombia, but especially in Japan. They stopped actively recommending the vaccination. So clearly giving a signal to the population and to the healthcare providers, you can still vaccinate, but we don't support it actively anymore. So I think that was key in Japan. I think also if we look to the crisis in Denmark, at a certain moment there was somebody diagnosing a syndrome that he had defined. And there the government said, let's take 1 million euros to further investigate these adverse events. So also not saying that, no, it's nothing, we continue vaccination and let's further look into that. That definitely you should look into everything, every signal that is reported. But as a government, if you take one step back, then you give a clear message, then there might be something wrong. So I think that's also common in Japan and Colombia. It's how also the government responds on that, and the speed of responding, also taking action to counter these things. Federico,
there's one issue on the measles vaccine and the autism story and Wakefield and that crisis. I think it is important that we acknowledge that this is happening and is still going on, and it's very high in their political influence in some countries, and that we don't refuse the discussion because we know that this hypothesis has been denied over and over and over again by very well conducted analysis and studies. What can you tell us and tell the audience in relation to this vaccine and the autism crisis?
Well, I mean, for a few things we can state so firmly that there is no link at all between autism and measles vaccination. We know it for sure first because we discovered it was a fake link, that Wakefield invented the job, invented the paper, and tried to make a business of it, trying to sue every pharma industry company to get the money for children and families with autism, blaming the vaccine for that. Before we discovered that was a fake thing, and as a matter of fact that paper was withdrawn, in parallel lots of serious, well-designed prospective studies were performed to discover that there was no link at all between autism and measles. So that's a fact. As a matter of fact, I wish measles vaccine was the cause of autism, because then we would have a way to deal with another big problem like autism it is, for which we don't have a perfect cure or perfect way to manage it. I wish it could be that simple, but it is not. We have discovered a lot of things related to that. We know that the diagnosis of autism usually happens by 2-3 years of age when we vaccinate, but the change that happen in the brain of these children occur already prenatally, before even being exposed to vaccines, and in children that have genetic predisposition, so it's totally unrelated. So the facts, again, the science is clear. But as you said, the problem is still there, because in the post-truth era, these things still are alive, and they are spreading the message that maybe there is a conspiranoid campaign against this Wakefield, which should be judged by, I don't know, an homicide against humanity. I mean, from hundreds of thousands of people have suffered the disease, and children are still dying because of this fake idea he invented, trying to relate both things. But despite that, again, we need more tools than evidence. We need specialists in social science, specialists in behavioral science, specialists in tailoring the message, specialists in really translating this evidence into the last vaccine, because vaccines only work if they are used. And no matter how the evidence support that, if we are not able to put that in the brain of the vaccinee or the father of the vaccinee. So, indeed, complex situation.
Any experience on the autism front by the others?
No, I think not lately. I think although still the shadow of Wakefield, it's a long one and a very, very damaging one, because false science has real damages in public health. I think that some of the tactics of the more radical anti-vaccine people has perhaps left out a little bit the autism thing, and they start talking about mercury or aluminium or autoimmune disorders, so they shift a little bit away once they face a stone wall, and I think that it's now clear for the vast majority of us. They try to find out other ways to convey the message and cast some shadow against vaccines.
No, and I think what they still are realizing is that we're now rediscussing this instead of promoting the benefits of vaccination, because we know there was no link, that it was fake news, and even so many years later we are still naming the guy and what he claimed that was completely untrue, and everybody knows it.
But he's still on active campaigns, and he's supported by this anti-vaccine lobby. He's being paid, he's making money of this, and there's still influential. That's the problem. So it's beyond science. It's that we cannot compete from a scientific perspective because everything has been said. So we need different tools. We need a multidisciplinary approach with all the stakeholders taking part, and probably taking measures that are beyond or above our capability as scientists or vaccinologists to deal with.
Yeah, because it is clear that the viruses always make their way, and if there is anyone that is not vaccinated, they will find it. And we now have 90,000 cases of measles in European countries, where we expected very few. And indeed, there's still this belief that measles is a minor, irrelevant, benign, gentle disease, and that you can organize pajama parties to reinforce the immunity of your children by sleeping together with a child with the measles. Yeah. But you showed this morning that measles can be much less pleasant than it is described in these rumors.
Absolutely. I mean, this is a terrible situation because it sounds like a joke, but it's not a joke. I mean, with this re-emergence of measles, which is, as we have been discussing, probably the first site of a decrease in vaccination coverage, being the most infectious disease, is the first one that reappears as soon as coverage decreases. But these specific measles parties and things like that are being promoted only reflects that you don't fear what you don't see, you don't know. And people forgot about measles. As soon as they will see a child die in their community, as it is happening now, they will immediately take action. There was, for example, as part of this crisis in the United States, as you know, there has been the worst measles outbreak in the last 25 years with a rapidly increasing number of cases. And there was some social media with anti-vaccine lobbies asking what to do now with the measles outbreak. And the answer is simple. Vaccinate your child, vaccinate yourself. But this gives you a picture, a snapshot of that. Sometimes these people is so close-minded that despite being dying and getting people ill around them, they still think that vaccine is not the solution, when it is so obvious from any other perspective. So the problem there is deep, and it's not scientifically driven. There are many other ingredients there that we should deal with.
So is this a sign that an outbreak of polio could occur, as you had in Spain this case of diphtheria after 38 years of not having seen any case in the country?
Well, indeed, I mean, vaccines work very well, but as soon as you stop using them, unless the disease has been eradicated, something that we have only achieved so far with the smallpox, the disease can return. And we have to consider also that we are living in a universal world where we move from place to place, so the herd community protection that you can achieve through vaccination can suddenly change when you get a plane and you change from city or from country. So we live in a global world where the disease in one extreme of the world can easily be transferred to another extreme of the world. The new pandemics, but also the re-emerging old diseases like we are facing now with measles. So indeed, we have to keep in mind that if we stop vaccinating, if we decrease our vaccination rates, the disease will come back. The first sign is measles, because this disease needs the highest coverage rate. We should be with 2 doses above 95% to ensure the interruption of the transmission of the disease within the community. But others will come. And we have seen examples, outbreaks in Spain, the diphtheria terrible case, in a more close community where the coverage was much lower than the average in the whole country. And we are seeing other examples, the tetanus case in the States with a child dying of tetanus because the parent didn't vaccinate him. And we can pick up several examples across the world. And diseases that were in developed countries almost forgotten, now they are reappearing, and mainly driven because the decrease in vaccination coverage.
Thank you. Let's move now to the flu vaccines. And I would like to ask you to explain a little bit the complexity of what flu is, because it is so routinely presented to the community every year, every winter, with very little coverage in the population and very dramatically little coverage in the health professionals that deal with patients with all sorts of diseases in the hospital. And that creates the sensation that this is one virus, one disease, and that production of vaccines should be relatively easy. Whereas when you go into the complexity of how many flu viruses are circulating at the same time with different frequencies in a given population, why vaccinated individuals still can develop vaccine because they encounter another strain. And particularly the challenging effort to identify and predict which flu virus will be relevant next winter, and to do it with time enough to produce hundreds of thousands of doses of this vaccine and distribute them on time to protect the population. Can you let us know a little bit?
Well, flu is a very particular disease. It's a very complex thing, as you mentioned, and unfortunately for us, it's quite complex because many of the issues that you have already announced. So flu vaccine also suffers from same problems that the flu changing of strains that I try to explain a little bit later on. Then, it's not a perfect vaccine. It cannot be, so we are in a different position if we compare with polio or HPV or other things. So we aim for efficacy rates of about 50-60% in the best scenario. It changes from year to year. That means it's not one shot for life or one shot every 10 years. So you have to be vaccinated every year, and that brought up the issue of you have to have confidence in the vaccine and the system, because each year we ask you to be vaccinated. And then because of the changing strains of the flu, first we have to anticipate what could be the dominant clades and the dominant strains for a particular season. In the northern hemisphere, in the southern hemisphere, that could be changed. It's not highly predictable what happens in the south, but what will happen next winter in the north. So we have very few information and we have to make a guess, let's say an informated guess, and say we selected at least 3 strains and actually 4 strains to be put in the vaccine. We can succeed or we can fail. If the virus changes, if there is a minor change, if there is an egg adaptation problem, there could be many factors that brought up the issue that the vaccine could not be as effective as we believe it should be this season. Thereafter, the main thing is that you mentioned is we think as flu as one virus. There is a soup of virus. There is a lot of variants of each strains and different clades, and that could not be enough, let's say, different antigenic diversity, but they could have enough antigenic diversity that are not properly covered by the vaccine. So in summary, as we said, flu is unpredictable, and that's the truth. It's highly unpredictable. We have problems to identify what could be the strains to be used in the vaccines, and thereafter, as you mentioned, we have to do that just 5-6 months in advance of the start of the regular season. Then it makes a lot difficult to change anything, provided that something new information arises. So we make the decisions on springtime for the northern hemisphere, and then set the instructions to the industry, start the production, keep the quality of the batches, keep the safety of the vaccine. It's a safe vaccine, that's clear. So it's nothing to argue about the safety of the vaccine, but it can fail. So many people say, I was vaccinated and I get the flu, although maybe they just get a cold, but they mix everything, so the vaccine is not effective in terms of what people believe. And then each year there is some sort of competition, how efficient or how efficacy, what is the efficacy of the vaccine this year. And we didn't barely rise upon 50, 40, 60%, the best year that we can. Is the real situation. Research could help us to find better vaccines in terms of effectiveness. Probably sometimes, I don't know, in the near future or in the long-term future, what we call the universal flu vaccine, a vaccine that could at least help to protect you to different strains. And again, as mentioned by measles, for most of the people, flu is let's say a mild disease, although you don't feel quite well when you have the flu, but still older people, younger people, people who had other disease can suffer very serious complications from the flu. And finally, just a word about the health professional. That's let's say, a very inconvenient truth for us. We don't vaccinate very much, 30%, 35%, even 25%, and that it didn't help at all to try to convince people to get vaccinated. If you confront one patient and you have some conditions and I recommend you to be vaccinated against the flu, then the question will, are you vaccinated, doctor or nurse? And if we say no, our credibility, it's down below. If we say yes, because I'm a health professional and I vaccinate myself every year, maybe the patient accepts the recommendation, but at least you have a stronger position in order to recommend it. Complex situation, many social factors, beliefs, different health professionals, but a difficult situation, and every year after every year is the same kind of situation.
And it's perhaps the worst case scenario if the health professional is strongly skeptical about getting the vaccine, even though it has been shown in many hospitals that, for example, cancer hospitals, the mortality due to flu is higher, and largely as a function of the vaccination rate of the professionals working there.
But we don't succeed.
We don't succeed.
No, we don't succeed. Year after year, we keep below 30% something. Remember, WHO rate 75% of flu vaccine coverage. So we have a long way to improve the vaccination coverage, especially for the healthcare professionals. How to do it? Yeah. I don't know. Many ideas will be welcome, social scientists, social marketing, campaign promotions. It had been tested many ways, but the reality, it's the same quite low level year after year.
But I think that addressing the skepticism and the growing skepticism regarding vaccination among healthcare professionals is a must, and it comes through education. Education from pre-graduate in the School of Medicine, even before becoming or seeing patients. I think this is essential. And we have clear examples of this difference in the perception, even in the real practice, not for ourselves as healthcare professionals getting or not vaccinated, but look at the example, for example, in maternal immunization. How the same professional is able to achieve 80-90% coverage with the pertussis vaccine in the pregnant women, and in that same women, 30% coverage with flu. Meaning that the professional does not actually believe it and is not actively promoting that vaccine as the other. While the evidence to support the flu jab in the pregnant women is higher than the evidence we had for the pertussis. And when the vaccination of the pregnant women has a dual role to protect not only the newborn but the mother itself, and at the end of the day the results are there. So clearly an example that duality exists, and we need to really cover those gaps with true education.
Okay, thank you. Let's move now to the HPV vaccine, the human papillomavirus. This is an infection that is linked to a number of cancers in the anogenital tract and is clearly related to sexual behavior. As such, cancer of the cervix is considered a cancer with a stigma. And the communication and the leadership and the visibility of groups supporting prevention of cervical cancer might be affected by that. Do you think that this is a relevant ingredient in the communication with physicians, in the communication with the press, in the communication with the media?
I think it has played an important role at the introduction of the vaccine, and the vaccine, as you said, first started cervical cancer prevention. That was the focus, and I think now 10 years later or even more, we have evolved, and it is really preventing HPV infection that is becoming the goal. It's not only cervical cancer, that has become clear also. Yeah. There's head and neck cancer, and it's not only a cancer of the women, but there's also a cancer in men. That's very important to address. So we are going to gender neutral vaccination, and I think sexual behavioral is not part of the discussion. I think with hepatitis B, at a certain moment, this was also a sexual transmitted disease, and it caused also some issues in the introduction and implementation of the vaccine. But I think we should definitely go to a gender-neutral vaccine that prevents an infectious disease that causes cancer in the long term. And it's very effective, and I think that should really be the message. And we had a meeting on healthcare providers and also the way of communicating. And sometimes we are over-communicating, because sometimes people go to their physician, and if the physician says, okay, today you will get 3 vaccines, and you say in the middle, and the middle one is for HPV, and people just accept the vaccines. And if there are questions, of course, then you have to explain, but certain, and quite a number of people go to their physician, and he's the person who knows what to do. And if he says, it's time for your vaccines, you get your vaccines. So I think we should normalize also vaccination a little bit. Yeah.
In this particular case, the challenge was that initially we focused on adolescent girls only. Then we expanded the age groups. Then we expanded to boys. Then we expanded to high-risk groups. Then we expand the age range, and now we are considering offering the vaccine to middle-aged women, because trials have shown that the vaccine is equally effective in middle-aged women, provided they are HPV negative at the time of vaccination. This is probably something that makes the message a little bit more difficult, because it keeps on changing. What would be your views on the novel approaches that are now being proposed of vaccinating middle-aged women?
So I think it's important to further invest in that, because WHO did call for elimination of HPV-related diseases or HPV infection as a public health threat. And I think we should invest to see which means can we use to do that as fast as possible. And definitely extending the cohorts is a strategy that could help in that. I think for most important is that we we keep our high coverage in our cohorts at 12 years old, because there we show that this is an approach that really works, but all the extensions should definitely be further investigated and see by modeling what the impact is. And as you know, there's still a lot of issues in how we can best vaccinate the older women. And I think in the current discussion, there's also specific for HPV, the issue of vaccine shortage that is being reported, and that makes it an ethical, more difficult discussion, because we are now promoting vaccines for elder women while there's a vaccine shortage for cohorts in developing countries where no screening is available. So I think we should also take that into account in the discussion.
Thank you. So we move to the last part of the conversation today, which is what can we do to improve our vaccination scenarios? And perhaps the first question is that, are we providing enough information to the professional? Can we do it better?
I think that we can do it better, and we must do it better. So as Federico mentioned before, it's a kind of education that I think should start at school, explaining the advantage and the problems with vaccines, whatever it is, with hygiene, with public health, with good diet, with exercise. All terms of public health should be taught at the school. Thereafter, in all the medical schools, nursing, dentistry, health science schools, there should be good information in order to understand quite well what a vaccine is, what a vaccine is not, what is vaccine hesitancy, how to deal with vaccine hesitancy, and things like that. And thereafter, because vaccination is a day-to-day changing world, new vaccines, new indications, changing of serotypes, and expanding the indications, the professionals are very difficult for them to follow up quite well all this changing of information. But we have to make a clear effort to explain quite simply, quite clearly, and to provide additional information if needed, since the primary school up to the whole life of a medical profession. My belief is that in part, healthcare professionals, but this is a personal statement, I have no proof at all, sometimes are overloaded with some sort of information and guidelines about many different vaccines, and they hear a lot of things, and they are very much used to adjust things on a day-to-day practice. They are very busy, they have to visit many children or many adult patients at a family practice, so at least they become a little bit reluctant because they don't understand quite well what's going on in vaccination, and they don't have enough time to keep updated with all things that surround the practice of the medical profession. If we are able to provide small capsules of information, small things, very clear protocols, not being in conflict, I think that would help, but certainly, and I stress that, it should be started at the very early beginning stages of education. If not, I think we will not succeed on keeping, not vaccines, but public health in general.
In fact, it was very interesting. Something that you presented in one of your meetings in Santiago was the idea that looking at the bacteria in the noses of children would predict the pneumonias in the elderly in the families during the winter time. And in many countries now we have this calendario per la vita in Italy, the lifetime calendar timetable for vaccination, because indeed vaccines are not anymore a story of children. It's something that keeps on expanding and offering benefits to the population until the elderly groups.
Yeah, I can't agree more. I mean, vaccines is not just a child issue. It's where we put the most of our energy, and the first vaccines available were focused on deadly childhood diseases. But nowadays we have to see it as a global, and our responsibility not only as healthcare professionals but as vaccinists goes across all life. I mean, it starts in pregnancy with the protection of the pregnant women and the fetus and even the newborn. It goes on with the childhood immunization program, which is the best acknowledged one, let's say. But then you have specific vaccines for adolescents, for adults, or even for elderly. And I think this will keep improving, thanks God, because we are doing a lot of efforts, and more vaccines will be soon available for specific groups. So we have to consider vaccine as a continuous part of our health control and health practice. And again, I'm linking with what Tony Trilla has just said, it means that you necessarily have to educate and update the healthcare professional to make this happen. Otherwise, we will fail. And this is key. I mean, we need the adequate feedback to really support and promote this essential information.
Alex, you did a survey on the quality of the education on vaccines at medical schools. And my recollection is that it was dismayingly low, the number of hours and the content that these medical students, which will become professionals, knew on the value of vaccines. Can you make a comment on that?
If I would say there's room for improvement, it's an understatement. No, so there's definitely lack on specific training in vaccinology. And if you go through Europe, every country is different. If you go to a country, every university is different. So it's really a patchwork of, and sometimes it's a professor immunology, and sometimes it's something infectious diseases. So there's no good overview, and at the end people are not well informed when they leave university, and it's very few hours that are spent, so this is also quite diverse. But this makes that if you are a young doctor, and all people say, oh, you're a doctor, can you tell me about vaccination? No, he cannot. He has not been trained properly. And for the general public, this is also not good, because they expect from somebody who had a medical education to be well trained about such an important tool we have to prevent infectious diseases. But it is really there's not sufficient attention given to it.
It's kind of a dramatic gap in transmission of knowledge. So just to close the discussion on this point, and it's a question for everyone, the concept of mandatory vaccination versus optional vaccination, opt-in versus opt-out vaccination. Can vaccines be imposed upon the population in our countries?
My personal feeling is, depending on the situation of the country and the situation of the public health, I will not advise to go to mandatory, let's say, vaccination, unless there is a public health emergency or crisis. That we have here in Spain some laws that allow us to use the power of law to make some sort of specific vaccine. I would go back to what Federico said at the beginning. We have to convince people that vaccinating themselves or their kids is the right thing to do. So we have to, this is the normal thing to do, and they should do this because they are convinced. They rely upon the health professionals, and they rely very much about the effectiveness and the safety of the vaccine. If not, I think that making it mandatory, besides some particular situations, will kick back, and then probably maybe we can handle one crisis, but we'll face an even more deep crisis. The final thing is, this should be discussed by the whole society. It's not a discussion by ourselves, the scientists or the medical profession. I think the parliaments, the representatives should discuss very openly what we should do if we, let's say, our vaccination coverage rates go below something, or what is happening in the UK, or what is happening in France, or what is happening in Italy. So each country should prepare, or should have his own different scenarios in order to use or not some sort of mandatory or recommended or opt-in or opt-out, or promoting adherence to vaccination.
Yeah. I make Tony Trilla's words mine, because I agree with most what he has just said. I would only add that we should consider changing from free to mandatory vaccination just a contingency rescue measure. There is no scientifically based evidence showing that switching from free basis or not mandatory vaccination to mandatory vaccination improve the coverage. It can cover a gap in a particular crisis, but it won't solve the problem. I think the solution is previous to that, is information, is education, and to avoid self-complacency. For example, we were discussing how measles is spreading worldwide, and there are countries that they are looking at themselves saying, well, here it is interrupted. And they are not doing anything different at all to those nearby countries to that country. So they should already put the measures now, before they lose the immunity or the interruption of transmission they have achieved. Because when that happens, then you have to go into measures like mandatory vaccination. So let's act now, because this is a global phenomenon. We have to identify, to measure what's behind the decreasing coverage. In general, will be vaccine hesitancy, but there may be specific issues that we have to detect, and we have to make tailored approaches to solve them. Don't wait to have the big problem. Try to seize that now and try to take the measures right now. And I think that's a very important take-home message for the authorities, for the different stakeholders. Avoid self-complacency, thinking that you are doing better than your neighbor country or less bad than the other one. You should get prepared for what is coming.
Would you like to add something?
Yes.
Good.
So I totally agree. For the general public, mandatory vaccination, it's only the last solution if there's really something that we should solve. But on the other hand, for the healthcare professionals, that might be another debate. I know in Belgium, medical students need to be in order with hepatitis B vaccination. If not, they cannot start the studies. Certain hospitals do recommend, or I ask the healthcare providers to be vaccinated against flu. So that's something that might be at a country level. There's also something in between that was proposed in certain Scandinavian countries, is to oblige the healthcare provider to offer the vaccine. Not to give the vaccine, but to be sure that the vaccine gets offered. Mm-hmm. And then I had one final remark on trying to educate the general public. We were just discussing how difficult it is to educate the healthcare providers. People that do 6-year medical studies, we are not succeeding to get across the message of importance of vaccination. So how realistic is it to really educate the whole population on vaccination? So I think we should have good communication, but we could never expect that people are so well trained and informed that they say, no, this is something I really need to have. So I think that's something that we should realize. We will never be able to communicate in such a way on all the different vaccines, all the different infections, as you say, all the difficulties in changing the cohorts. If we want to educate the general population on that, I think we will not succeed, so we should find other ways involving the healthcare professionals that have a one-to-one relation with the general public to communicate better on vaccination.
Yeah, but for the general public, we need to set the frame. I mean, you know that if you cross the street with a red light, you are free to do it, but you know you are doing the wrong thing, and that's education. So we need to do the same for vaccines. I mean, you're free to decide, but you should know that if you don't vaccinate yourself or you don't vaccinate your child, you're doing the wrong thing. And for that, we need to educate early on, and I think that will really change the scenario.
Because if you cross a red light in Belgium, you need to pay a fine. Huh? It's obligatory to stop before a red light.
Okay, so it's been a pleasure to have that discussion. Going back to the introduction, vaccine hesitancy is becoming now problem number 8 in the priority list of the World Health Organization, a phenomenon that would be unthinkable at the time where people were so happy to have eliminated smallpox, at the time they were able to curtail a major disaster, which was the polio epidemic worldwide. It is now quite of a surprise that we are confronted with a position, both professionals and public in general, that they refuse vaccinate and they expose themselves and their children to diseases that were supposed to be out of our agendas. So I'll leave you a last word in case you want to recommend something, underline one of the points that you think are more relevant at this stage.
Well, I think in terms of vaccine hesitancy, we should not make assumptions. It's a real problem. The cost can vary from country to country, so it's important to identify and to make a multidisciplinary, multi-targeted approach. And what is in common behind that as a solution is the information and education from both the lay public, from the early ages, from the kindergarten, to also the healthcare professional side.
So I sincerely trust that this discussion will help in that direction. And I thank you very much for your attention.